Tanna sir even explores the various postures where he can participate also.
That is the next Zoom meeting.
But it's a wonderful platform, and the time everyone has, it's a good platform.
No,
to
this
share.
is a good idea, I think.
Good idea, yeah, good idea to share. So just waiting for Babulkar sir.
Right.
And then we start.
How there is a bridge behind you, Ashok?
It's a virtual background, sir.
हम लोग का साला घर में बैठा है, तू किधर बैठा है?
मैं भी घर में ही बैठा है।
अशोक का ऐसा है ना सर, वो मीटिंग के हिसाब से पीछे का बैकग्राउंड बदलते रहता है उसके अंदर वो।
You can also do it, sir. There is a possibility in Zoom to choose a virtual background. There are 4 virtual backgrounds.
भैया हमारा एक बैकग्राउंड अच्छा है, हमको हम तकिया पे सोया है खाटले पे।
It's a virtual background, sir.
हम लोग का साला घर में बैठा है, तू किधर बैठा है?
मैं भी घर में ही बैठा है।
अशोक का
Yeah. Okay, so we are, I think, ready to move on.
Babulkar sir, how do we interact with
We'll wait for him for a few minutes.
Just 1 minute we wait.
Ashok, this is San Francisco behind you?
Yes, sir.
Ah.
But you can change it yourself also. आपका भी change हो सकता है.
अभी ये साला बुढ़ापे में कितना सीखेगा अभी यार? आप लोग इतना तो सिखाते हो हम लोग को.
सर आप लोग सिखाते हैं, हम लोग सीखते हैं.
People from VOS1 and VOS2 group are asking link, but do we give them the Ortho TV link?
Yeah, that is fine.
That is fine, no?
Yeah.
Ashok, are you busy morning, afternoon and night doing these things?
Yes, sir. Nowadays, yeah.
Yeah, I'm talking about this period.
Yes, yes.
Sir. He is conducting, I think, 3-4 meetings every day on web.
Yeah, I can imagine that.
Babulkar sir is still not joined. Can we?
Okay, he's joining.
Yeah, that's all.
He's joining.
Good afternoon, sir.
Good afternoon,
His
sir.
audio is not yet connected. He'll connect.
Yeah. Audio is yet to connect.
Raju.
Yes, sir. Good afternoon. Welcome.
Good afternoon.
Good afternoon.
Good afternoon.
Vijat. Good afternoon.
Good afternoon.
Hi, Sudhir.
Hi. How are you?
Getting on.
Taking rest? Sleeping?
So now we are on.
Very high.
Yeah. So good afternoon, sir. We are all live on the YouTube. So we'll start the meeting proceedings. So friends, welcome for this webinar on ligamentous injuries around knee. And the topic is avulsion injuries around knee. So we have 2 faculties who will be talking. Dr. Kakatkar, Dr. Vijat Kakatkar from Nasik. He will be talking on avulsion injuries around knee, especially the bony avulsions. And after Dr. Kakatkar's lecture, we will be having question answer. 5 to 10 questions we will be taking. And then after that, Dr. Sachin Tapas will be talking on avulsion injuries of the posterior cruciate ligament. He would be telling us both the ways of management, the fixation, the open ways, and the orthoscopic way. And we also have an expert faculty for expert comments, Dr. D.D. Tanna from Mumbai and Dr. Sudhir Babulkar from Nagpur. And our friend Dr. Ashok Sham has provided us a wonderful platform for this meeting. Ashok, can I ask you to narrate few tips for joining on this webinar so that everybody is benefited?
Right. So the webinar is streaming live on Ortho TV website. We have shared the link of Ortho TV website. For people joining on Zoom, there are 2 ways to join Zoom. One is through mobile app and second is through a laptop. Whenever you're joining, just close all the Zoom apps on your laptop as well as mobile, just click the Zoom link directly on WhatsApp or email, and it will automatically open. If you keep the Zoom open prior to clicking the link, it will cause an error. So simplest way is to close everything and then just click the link and join. While joining the Zoom meeting, after you join, keep yourself on mute and keep your video also off while the speakers are talking. During the meeting, you can either raise your hand virtually or you can use the chat box to ask questions. For this meeting, questions can also be asked on my WhatsApp number. You can send me questions and I'll convey to the speaker. Send your questions in brief as well as with your name and city so I can ask the question properly. So that's the brief about the meeting. Go ahead,
Thank you,
Chandrax.
Ashok. Thank you, Ashok. And I'll now invite our speaker, Dr. Kakatkar. He'll be speaking on ligament injuries, avulsion injuries around knee. Welcome, Dr. Kakatkar, sir. Can you share your screen now?
Yeah. It's not going through.
For our
Yeah. I'm through.
yeah, it is coming up, sir. It may take
Yeah.
some time. Yeah. We can go on the presentation mode.
Yeah.
Welcome,
Can
sir. You can
everyone
start
see?
the lecture. Yeah.
Hello. Can everyone see? And
Yeah, we can
Yeah.
hear you.
yeah. So good afternoon, everyone, respected teachers and my colleagues and friends. We are trying to make best use of this compulsory curfew through which all of us are going. And with the help of Dr. Ashok, we are organizing this webinar in which I am going to talk to you today about the ligamentous injuries around the knee. The ligamentous injuries around the knee can be intersection injuries which are mainly tackled arthroscopically, and avulsion fractures, either extraarticular MCL, LCL, or even ACL, PCL, can be tackled either arthroscopically, and the collaterals and the ACL can be tackled open also. The avulsion fractures can be isolated avulsion fractures, or they can be associated with the fractures of the proximal tibia, which is quite common to see. I'll start with a case. This is a 15-year male. You can see an ACL avulsion, and this was a piece which was separated, and in the lateral view, you can see this is being lifted up. This was fixed open. This is an intra-op picture. You can see the piece completely lifted up and the ACL completely intact behind. And after putting it back into its bed, 2 screws were used to fix this particular fracture fragment. And behind that, you can see a intact ACL, which is very obviously seen. This is a post-op X-ray. You can see the 2 screws and the fixation that is done. You can also see a very small chip fracture on the lateral condyle, which did not need any treatment because there was no problem of instability on that side. This is a 1-month post-op X-ray. You can see the fracture has started joining up, and this is the function at the end of 1 month. I'm sorry for these pictures because the pictures were sent by the patient on the mobile. So instead of giving him directions, they couldn't really send proper pictures. Another case, 58-year male, and this is a PCL avulsion. You can see a big piece of PCL completely lifted up, and this was tackled open by a Berkshire approach, and this is the approach wherein you go in between the semimembranosus and the gastrocnemius, and you are right onto the PCL. And this was again fixed with 2 screws. This was a big fragment, so I could put 2 screws through that. This actually is an extra-articular fracture, not actually going inside. So you can go without doing an orthotomy, you can fix this particular PCL fragment. This is a 3-month follow-up, and this is the function at the end of 3 months, complete range of movement. Another 20-year male, this was a ACL avulsion, plus there was MCL avulsion at the tibial side, not a bony avulsion, and there was a gross mediolateral laxity. So this was done with the anchor on the medial side where the tibial avulsion was repaired, and the orthotomy by which the ACL fragment was fixed with 2 screws. This is a 4 months post-op picture, and this is the function at the end of 4 months. This picture the patient has sent to me today, so he is relaxing at home and probably sitting on a sofa, and he sent this picture. If the bony piece is small and is not amenable to fixation with a screw, you can pass a fiber tape through the substance of the ACL, and you can put 2 K wires going into the footprint of this ACL, and then you can, as a pull through, you can fix this particular fragment. Of course, I couldn't, though there were some cases, I couldn't get a case today to show. This is a 28-year male. This is a MCL bony avulsion. You can see a piece of the bone from the medial femoral condyle avulsed with the MCL. Luckily, there wasn't much other injury into the capsule and the other ligaments. So I could fix it with a spike washer and a screw, and the stability was achieved. So this is a 3 months post-op X-ray. This is another 50-year male. This is ACL avulsion plus PCL avulsion, and there were cracks extending into the medial and the lateral condyle of the tibia. So now we are going from only isolated injuries to the injuries along with the tibial condyles. And this was because the tibial condylar fractures were not very badly displaced. So this was fixed with 2 screws from ACL, PCL, and 1 screw to fix the condyle lateral side. This is a 6 months follow-up, and at the end of 3 months when he had come, we had taken his pictures for the function. This was the picture. Another 37-year male, this was an ACL avulsion with fracture of the posterolateral part of the tibia, which is not very obviously seen in the X-ray. I have pointed out with an arrow where you see some double shadow in this area, and you can see a piece of ACL which was lifted up, bony avulsion. And this is a pre-op scan which shows this bony avulsion of the ACL, and you can see a depressed posterolateral part which is more clearly seen in the axial and the coronal cuts. You can see on the posterior side near the intercondylar notch, the posterolateral part of the tibia depressed. This was through a small window lifted up posteriorly, and the bone substitute was used to support it, and ACL was fixed with 2 screws. And after putting the bone substitute and elevating that fragment, a screw was passed posteriorly to fix this particular fragment. This is a 4 months post-op. This is a 15 months follow-up. He is the son of one of the doctors who is known to me, so I could get the pictures in spite of this curfew. And this is the function at the end of 1 year. Another 30-year female with ACL avulsion and type 3 lateral condyle depressed fracture. You can see the outer cortex of the lateral part of the tibia being intact, and this fragment was depressed. This is a CT which shows this particular bony avulsion from here, and you can see a very thin rim remaining on the lateral side. So this was fixed with the 2 screws for the ACL fragment, and for the lateral condyle we just passed 1 screw with a washer, And for the rim, I had to, because the border was so thin that I had to just pass 2 K wires and fix it. Luckily, the function after the surgery was good. At the end of 2 months, she had full range of movement. Another 48-year male, this was a lateral condyle which was completely displaced posteriorly and was almost lying perpendicular to the shaft of the tibia. And there was an associated superior tibiofibular dislocation with fracture of the head of the fibula. And this was approached by a modified posterolateral Frosch approach. And this is the approach which I have diagrammatically shown. And these are the structures, how you go in between, and after erasing the soleus, you can go on to the fracture. And this is a modified approach in which you don't have to dissect the common peroneal nerve, and you have to go little medial, 1.5 centimeter medial to the fibula, wherein you can avoid dissecting the common peroneal nerve. And this is fixed by this modified Frosch approach. And anterior approach for putting a lateral plate after getting the fragment in alignment, and the posterior piece after getting it corrected was fixed with 2 screws, and the fibula was fixed with 1 wire, and there was a vicryl stitch taken around that wire to stabilize that particular fragment. This is at the end of 1 year when we have removed the plate, because he had a very low grade infection in that area. But then the posterior screws and the wire was left. And this is the function at the end of 1 year. So it was initially a very bad looking injury, but luckily we could get excellent function. Another 45-year male, completely rotated piece of the articular surface of the lateral condyle plus ACL avulsion, and there was a fracture extending onto the medial side also. And you can see there was a metaphyseal extension of the fracture going down also. This was a CT scan with 3D reconstruction. You can see that piece of the lateral condyle was almost vertical in this particular position. You can see it very clearly over here. So it was quite tricky to get this piece back into the joint. The joint was completely open on the lateral side, and we could get the entire articular surface reconstructed. The ACL was fixed with the 4 millimeter cancellous screw, and the postomedial condyle piece which was seen was fixed by an anteroposterior screw, because otherwise it would have become too extensive soft tissue dissection for fixing both posteriorly and anteriorly. So this is the function. After 10 days, the patient was put on a CPM, and he already had about 90 degrees of movement after doing this surgery. Another 57-year male, ACL avulsion with lateral condyle depressed fracture. And this was used, and this was fixed with 2 4 millimeter cancellous screws for the ACL fragment, and the lateral condyle was lifted up and bone substitute was used, and a lateral plate was used to fix the lateral fragment. There are certain tips and tricks, because there are a number of situations wherein you get the fracture of the tibial condyles wherein you are putting the plate, and if you are doing fixation of the ACL fragment afterwards, it becomes quite tricky. If you use a drill bit, it is likely to go and hit onto one of the screws and it might break. So one trick which I use is, instead of using a drill bit, I use a 2.5 millimeter K wire, which has no risk of breakage even if it goes and touches on a screw. So you can use a K wire, and that K wire can be withdrawn, and you can just adjust the direction to get your ACL screws inside. Another advantage of using a K wire is that when you are going through the bony fragment of the ACL, many a times if you are using drill, many times it can entangle the fibers of the ACL because of the threaded nature of the drill bit. But if you are with a K wire, you can avoid this injury to the ACL fibers also. This is solid union and the plate removal at the end of 2 years. Because the plate was removed by a different incision, the ACL screws were left inside because they were not bothering the patient. And this is full function at the end of 2 years. Another 45-year male, this was a posteromedial condyle with ACL avulsion. And this was fixed by 2 screws for the ACL fragment from the front side by the medial parapatellar, and posteromedial approach to fix the posteromedial condyle uh, by a separate incision. And this is a 2 months follow, and the patient had excellent range of movements. So the take-home message is that in avulsion fractures, along with the X-rays, CT scan is absolutely mandatory to give you idea about the intra-articular injury of the upper end of the tibia. You should aim at hairline fixation of the avulsion fractures along with the tibial condyles as a general principle of treating any intra-articular fracture. And you should be able to get a very stable fixation so that you can start early mobilization to get the best possible results. So thank you very much for the patient listening. If there are any questions, I'll be very happy to answer.
Thank you, Kakatkar sir. That was a fantastic display of all the cases, and it showed almost very difficult cases nicely fixed up with full follow-up. Thank you so much. Any opinion from the faculties on this? And then we take up the question.
Dr. Kakatkar?
Yeah. Yes, sir.
Can you hear me, Vijay?
Yes, I can
Yes,
hear
sir.
you.
You were very fortunate that each one of them were a very big piece which you can fix it up with the screw. But
Yeah.
often enough, it is not a big piece. And then
Yes.
you will have to use the tension band type of a situations which has to be going down. So I
Yes,
didn't
I
didn't
mentioned
see
it
any
in
one of them. So
No, I have done few of them wherein I have used a fiber tape and put a screw as a post and fixed them. But unfortunately, I couldn't get those patients. When the fragments are small, I mentioned in one of the slides that you have to use that
yeah,
tension
I
band
heard
kind
that.
of a thing. Yeah.
But when you use that fiber tip,
Yes.
only one strand of a tension band type of a fixation,
Yes.
it can really lift up the ACL, the bony piece.
Yes.
So you will have to use it two fiber tips, one
Okay.
posteriorly and one anteriorly,
So that it
will be-
presses it completely down.
so that it can remain completely down. Otherwise, you will see that it is slightly projecting up anteriorly. And that's the
Yes, sir.
reason this is what was my feeling, that if you are using a fiber tip or any other fixation of a tension band type,
Yes.
you will have to use two fixations and not only one.
Okay. I think it's a very valid suggestion, sir. Yeah.
I have a question.
Yes.
Yeah, the question is that many a times people struggle with getting their ACL avulsion fragments reduced properly in the bed, especially if it is an injury which is about 10 days old or 12 days old. So, what are your tips and tricks, for these so-called not so easily reducible ACL avulsion fragments, and what are the common soft tissue impediments that you normally encounter, which you sort out when you are doing surgery on them?
See, one of the commonest problems that one faces is that the part of the meniscus is number of times actually partly overlapping onto the bed of the ACL. And one has to use either a small skin hook-like retractor or a small cat's paw retractor by which you can just lift up that particular part of the meniscus so that you can get a very clear view of the entire the bed of the ACL fragment, And then once you have got the ACL bed exposed, give a thorough wash, clean out all the clots from there. And then what I do is I put a towel clip at the junction of the ACL with the bony fragment. And the other tongue of the towel clip will be on the medial tibial condyle. And then you pull that particular piece with it and temporarily stabilize it with thin K wires, 2 K wires, so that it doesn't rotate. and then you can go ahead with a definitive fixation. I think that makes one of the most important common obstacles is the meniscus that comes in the way of your visualization of the bed.
Yes, so definitely the intermeniscal ligament or the anterior horn of the lateral meniscus is very closely applied.
Yeah.
Dr. Chandak has a very interesting technique where he has devised some special cannulated screws with short threads. Dr. Chandak, would you like to tell us how you've devised them and how do you do it?
Yeah. This is what I call as a percutaneous method of fixation of the McKeever type 1 and type 2 ACL avulsions. It cannot be applied to McKeever 3 or 4 where there is fragmentation. So when the ACL avulsion is just popping up, what we do, take the knee in complete extension, have a small probe, orthoscopy probe, which can place it from the top. If the fracture is well aligned, everything falls back into position, then exactly graded screw, 1 millimeter difference screw with a thread length which is just 12 mm, not the complete 16 mm thread length. So they can hold the screw from anteriorly. The best advantage of this is the ACL fragment is lifting like this, and then we are taking the screw trajectory down. So it fixes it back into the bed. But this would fail if there is a soft tissue impediment. In that case, it would require either an open or orthoscopic procedure to fix it up.
Okay. Nice idea.
Raju,
Yes, sir.
Raju, I have questions to Dr. Vijay.
Yes, sir. Go ahead.
Can I-
Yeah, go ahead, sir. Everybody is
Yeah,
Yes,
listening.
sir.
Most of the time, posterolateral condyle fracture of tibia associated with ACL injury, he has taken a posterior approach, but put only 2 screws or 1 screw and not the buttress plate. Instead of fragment big, where he could put a small buttress plate, he has chosen only 2 screws. Any,
Yeah. Yeah, I
Vijay,
think
any,
once, yeah, I will explain, sir. See, most of the times what happens is that because you are planning to put 2 plates, if you are planning to put a plate on the posterolateral or posteromedial fragment and even on the lateral surface, then there is too much of hardware inside. You know, the screws go on hitting each other. So if you put only 2 screws and if you are able to get a stable fixation from behind, then at least this crowding of the screws in that area can be avoided. But where there were only posteromedial condyle fracture, there you have seen that I have put a plate because there I'm not worried about the screws entangling onto each other.
I am talking
But when
about
there is a
posterolateral
no,
fragment.
in the posterolateral fragment also, after the posterolateral fragment, I have put a plate on the lateral side again. So there were, if you put screws from behind as well as from the lateral side, they become too many screws and they start actually hitting on each other. And the posterior side, you operate in a prone position, and then if that screw starts coming in, it becomes difficult when you have already turned the patient supine to do anything. So
Thank
if
you.
there is only posteromedial or a posterolateral with ACL, I would put a plate behind. But if it is associated with a lateral condyle or medial condyle, wherein you have to put one more plate laterally, then I would prefer putting only screws behind with washers so that you don't have too many screws in the proximal part.
Hello, but with the
Yes.
first approach, you can put posterior plate as well as a lateral plate through 2 different windows.
Yeah. But
Your
then
opinion?
I have used a modified frosh wherein it is difficult to put a lateral plate from that.
Okay.
Wherein you go medial to the fibula. Go medial to the fibula, wherein you cannot access on the lateral side of the tibia. You have to go by a different incision from anterior side for the lateral plate.
They make an anterior window to the
No,
same
but then
incision.
from the modified this thing, you can't make an anterior window from that because you are almost completely posterior.
Okay.
Okay.
And
you,
you
sir.
say a force approach.
Yeah, modified frosh.
You don't encounter a lateral popliteal nerve.
In modified frosh, you don't encounter the lateral popliteal. You don't have to dissect and retract it.
No, dissect and retract is different.
Yeah.
But identifying and avoiding, I thought that was mandatory.
You can identify, but you don't have to dissect and retract it.
It falls down itself.
Yeah. Because you are a little more on the medial side, so it doesn't come in your way.
So
Then it doesn't become a force approach, no?
No, it's a modified Frosch approach. It is described, sir. I have given the references. If you want, I can just go back and show it to you.
yeah, put that slide up again.
Yeah, I'll just put up that slide again.
Yeah.
Yeah, this is the modified Frosch approach, wherein there is an 8 centimeter incision, 1.5 centimeters medial to the medial border of the fibula. And you don't have to dissect the common peroneal nerve. The lateral gastrocnemius is retracted medially along with the tibial nerve and the popliteal vessels, and then directly you detach the soleus. Whereas in this classical Frosch approach, you have to dissect the lateral popliteal nerve and you have to retract it. Then only you can go on to the soleus.
So when you call it a modified force,
Yes.
isn't it the posterolateral approach normally what we take? What is the difference between that? I'm just trying to understand that.
So in the Frosch approach, actually you go on to the fibula directly. The incision is centered over the fibular head in the Frosch approach. Whereas in this approach, your incision is medial to the fibula.
So do you do it in a lateral position or you do it in a prone position?
Do it in a prone position. Do it
So
in a
that's what
prone
I'm
position,
saying.
sir.
That is what exactly what I understand is what you are doing is the posterior lateral approach, and probably you are giving it as a name as a modified force.
No, it is something which is described, sir. There is a reference given at the end of the slide.
No, I can see that reference here.
Yeah.
Dilip,
Yes.
in
Yes.
this posterior, in the force approach, the patient is in lateral position, not
Now,
in the
he's doing it in
sequoia.
prone position, ne?
No, this modified
No.
Frosch is in prone position, sir.
Prone position is doing.
Yes. This is modified Frosch is in prone position.
No, force original approach, patient is in lying down position.
Is in a
And
lateral position.
Lateral position. So you have an access on the anterior as well as the posterior side.
That's right. Where you can
Yes.
put plate posteriorly as well as laterally.
As well as laterally through the same by anterior
Whatever
window.
the name you give, whatever you name you give, you're doing it in a prone position where you are going medial to the fibula and you are going medial to the popliteal nerve.
Yeah.
Yeah, fine.
Yes.
And the other question which I had was that MCL which you put in the screw.
Yes.
Did you test it that it is unstable and that's why you did it? Because this MCL is small flat.
Yes, I tested that there was a
attached with the ligaments around.
No, there was a opening up on the medial side, but then it wasn't very gross. So I just fixed up that particular bony avulsion attachment, and that was good enough.
Now, if I can ask you in that bony attachment which you fixed it up,
yes,
it was the end of the MCL. MCL was also going a little more proximally to that also.
Some fibers were going even proximal to that, but the main chunk of MCL attachment was on that particular piece.
Yeah, this is what exactly I am asking you. That if it is not the end of MCL and some fibers which are there which are attached proximally,
yes,
which are not avulsed out,
yes,
then whether it needs fixation, it is what I was asking you.
Yeah, if you get bone to bone healing in that area, I think the stability achieved is much better.
Fair enough.
Yeah.
Ashok, do we have any question on the chat box?
Yeah, we actually have many questions.
So we can take 5 questions.
Yeah. So this is one question from Dr. Vijay, from Dr. Taneja from Punjab. What is the ideal timing to operate a case of ACL, PCL, and MCL considering the soft tissue problem? And what is the sequence of fixation?
Well, if there is only ACL avulsion and MCL avulsion, then I think earlier the better, because then there is not problem of too much of soft tissue edema like you have with the condylar fractures. But if there is an associated condylar fracture, then I think you have to wait till the edema in the proximal part of the tibia settles down, then only you should go in. Otherwise, there is always a risk of landing up with skin necrosis.
Okay.
Right. Sachin sir, you have some different opinion on this?
So are we talking about avulsion fractures or are we talking about ACL, PCL, MCL mid-substance tear? Because I think what the
I think-
question was alluded to, probably I think he was speaking of more of a multi-ligament injury rather than an avulsion.
Right.
Yeah.
Right.
Yeah. So I think that that actually depends upon two factors. Associated injuries. Are there any other associated injuries which take precedence? Number one. Second is, what
Right.
is the knee looking like? If the knee is looking very angry, very intense, then in that case, a staged approach is better, in which one could do a stage 1 MCL at around 7 to 10 days, and then come back later around 3 months to do an ACL with PCL. However, if it is a moderate low velocity multi-ligament injury and you have a compliant patient, then you can do all three ligaments at the first go at around 7 days, and you can greatly shorten the patient's rehab time. But you require a compliant patient who's going to obey and listen to you and do his rehab properly, which is, I think, the good answer to give for this particular situation.
Any other question? We
Right.
take Ashok.
Yeah, there is another interesting question by Dr. Tejas. He asks about proximal tibia fibula joint disruption along with other injuries. Do we do anything for it, or how do we tackle it?
Well, in that particular patient wherein I have shown that the
Yes.
posterior posterolateral piece which was there, once I put it back, the overall stability of the tibiofibular syndesmosis also increased. And then in addition, we fixed the broken fibular head also. Once that was done, it became quite stable.
So Ashok, if
Right.
I can add to this particular question here, is that proximal tibiofibular disruptions are probably more common than what we think. It is very unusual to get an isolated proximal tibiofibular disruption, and the same principles apply of that of, say, doing an ankle fixation. If you find that after fixing your lateral tibial plateau, you find that there is instability at the proximal tibiofibular joint, I think you should fix it either with the help of sutures, or you can put a screw across from the fibula into the tibia and leave it in there, and that will help sort out a lot of problems. And these patients usually get pain afterwards because they start developing a ganglion cyst in that area, and that usually gives rise to sort of late neuropathy like pain for a lot of these patients.
Right.
Well,
In
one
this
question,
setup,
Sachin, I have.
Sachin,
Yes, sir.
when there is a dissociation of the tibia and the fibula,
Yes.
you don't get any injury to the LCL.
Yes. So this is definitely a part and parcel of a multi-ligament knee disruption. And just like how you would, if you were, say, doing an ankle fracture, you have fixed the lateral column, and now you would normally always test for the syndesmosis and see if it is intact or if it is disrupted, and you would always go and do something for the syndesmosis. Same way, I think it is important for all of us to also understand and realize that once you're dealing with any injury around the lateral side of the knee, whether it is a ligamentous disruption or whether it is a fracture of the lateral tibial condyle, it doesn't harm to just test for the integrity and stability of the tibiofibular joint by moving it anteroposteriorly. And if it is unstable, then I think fixing it is of good importance.
But you won't have to
Sachin.
do anything to LCL.
Not really. An LCL will present in a different manner. So you can have a proximal tibiofibular injury as a part and parcel of a posterolateral complex injury pattern, or it could be a part and parcel of a lateral tibial injury pattern. So either it comes as a part of the ligament, or it comes as a part of the bone on both sides.
Sachin, I have one question. See, many years back, Bombay Orthopedic Society had published one video cassette in which Dr. K.T. Dholakia's close wedge high tibial osteotomy was demonstrated.
Correct.
And in that, the technique that he used to use was a horizontal incision, and then he used to go to the superior tibiofibular syndesmosis, release the superior tibiofibular syndesmosis. He
Correct.
used to put a periosteum elevator and mobilize the fibula,
Yeah.
fibular head, so as to get that syndesmosis opened up, and then through that particular gap he used to do a close wedge osteotomy.
Correct.
So in this kind of a situation, his claim was that without doing any fibular osteotomy, the fibular head slides up when you do a close wedge. So wouldn't it create a instability in the tibiofibular syndesmosis, and can it be troublesome?
But
Nowadays,
if it,
not many people do that osteotomy, but then because we have done it in the beginning, many of these patients, but surprisingly, we never had any issues with them. I think
so
Tanna sir and Babulkar sir also will agree with this particular
Yeah,
technique, which
this
was
this was a routine surgery.
yes,
If we didn't do the fibular osteotomy, because the fibular osteotomy had to be done lower down,
yes,
with that same incision, we used to release that what you described.
yes,
And somehow, if I can say, I don't think there was any problem with the tibiofibular joint at the end of the whole surgery,
yeah.
or
That
at
is
the
what
end of 4 months, 5 months also.
I mean, I would
It
definitely agree with you. This is a controlled release of the tibiofibular joint. Probably since we were doing it in osteoarthritic knees with other pain sources and stiffness, it never was that apparent. We never got a chance to really study what sort of instability those patients had later on. But when it is a part and parcel of an injury in which it is a directed force, abnormal directed force, which is causing disruption of normal tissues, probably I think it may present or it may lead to different outcomes.
Ashok, any other question on after this? And then we start the next lecture. One
Yeah,
more
there
question.
is one more question that talks about what is the threshold for fixation of ACL avulsion fractures? In presentation, many undisplaced fractures, avulsions were also fixed. So when will you conserve and when will you fix?
well, if there is a separation of the bony fragment, none of the fragments which were not displaced was fixed. All of them, if you see in the CT, you could see that the piece was lifted up. And if you don't fix these fractures, and if you fix the only condyles, then early mobilization becomes difficult, because the moment you start mobilizing and bending the knee,
I
this
think Dr.
particular
Kakatkar sir's
ACL
audio
will.
is not being heard.
It is being
Is it?
heard.
You are able to hear me?
Yes,
Now
sir.
we are
Go
hearing
ahead.
you.
Yeah. So if you, in most of these patients where there is an associated tibial condyle injury, the aim of treatment is to mobilize them as quickly as possible. In fact, we start on CPM on the day 5 or day 6, as soon as the edema settles down. So if you don't fix these ACL fragments, which apparently look not very major displacement is seen in the first X-rays or in CTs, the moment you start bending, they start getting separated, and then it becomes difficult. So it is wiser to fix them up right on the day one when you are fixing the condyle, so that your mobilization doesn't become problematic. I think
Yeah. And also, if you don't
the
fix, it leads to a fixed flexion deformity. The knee doesn't extend completely.
yeah, that also happens because it gets lifted up, and then if it joins in that position or it remains there, it causes definitely FFD. So
Yeah, I
this
think
is
some
There
of
is
the
a,
cases,
yes,
some of the
yeah.
cases where we had seen that the surgeon had conserved that small part of ACL avulsion, patient walks about and moves about. The only disability he has is a flexion deformity.
yeah,
And they do not have the instability. Whatever you try to demonstrate the signs of instability, there is no drawer test or anything, except there is a flexion deformity.
yes.
That is a very important point.
So,
Sir, there are two more questions. Can I take them?
yeah, I take them right now. No problem.
Yeah. So one question is from Dr. Vikas from Gwalior. He's asking if there is a posterior medial and a posterior lateral condyle fractures and there is an ACL avulsion. What will be the approach, surgical approach to tackle all these three injuries?
It will have to be tackled by two different incisions. You have to go posteriorly, and instead of taking either posteromedial or posterolateral, you can go by a Lazius approach by which you can lift up the skin flaps and you can approach both posteromedial, posterolateral side, and then come anteriorly and then do a separate fixation for the ACL.
Right. Sachin sir, you have a take on this?
Yeah, I think I would agree with what Dr. Kakatkar says, is that the posterior tibial condyles, both of them, would need to be tackled with rigid fixation by doing good proper open reduction, and then you may come back later, flip the patient over and do anteriorly and fix the ACL with whatever
Right.
modalities you feel more comfortable with.
Just to add on to that,
Ashok,
Yes, sir.
sir, can I just add and then you
Ashok.
can. Hello, sir.
Yes,
Yeah.
sir. Go ahead. Go ahead. Babulkar sir, go
Yeah.
ahead.
Instead of taking one Lazius incision, I would prefer to take two incision, posteromedial and posterolateral. Comparatively, those would be small incision. Do the fixation of posterolateral and posteromedial condyles after reduction, and then come with the anterior approach for the ACL.
So three
So
incisions.
three incision.
Because if the posterolateral part is displaced, it is very difficult to do it only from the medial side going underneath and try to get that fracture very properly reduced. So if it is buttressed, all right, but if it is not reduced properly, and if at all there is a depression on the lateral side also, then you will not be able to tackle by only posterior-medial approach. Then that's the reason why it may be mandatory to take exactly as Dr. Babulkar mentioned, posterior-lateral, posterior-medial, posterior-lateral, and if you need it, then you can take a force approach for the anterior and posterior part of the tibia there.
Sir,
Right.
can I add something? There is a recent new classification described based on the CT, wherein they have said that instead of 3-column classification, what they have said is there is a
10 column.
triangular piece, which is bounded by the anterior and posterior border of the fibula, which is a posterolateral condylar piece. And in this new classification, what they have said is that this particular piece, if it is associated with a lateral condyle, it should be treated as lateral condyle. And if this piece is associated with the posterior part of the tibia, then it should be treated only as a posterior condyle. And you can fix either, if it is with lateral condyle, treat it as a lateral condyle fracture with plate, and you don't have to fix that posterolateral part again. This is a new concept, which a new classification which has come up, modification of the 3-column concept. So if we take that particular concept in our mind, then there is no need of going through two different incisions. You can go by one incision and you can put one plate and take care of it.
Ashok, I
Right.
think one more question is pending.
Yeah, one question is quite complicated, asked by Dr. Mukesh Ladda from Nagpur. If we have both ACL and PCL avulsion with an MCL grade 3 and a medial tibial plateau fracture, how do we approach this patient? Both ACL, PCL avulsion and MCL grade 3 with a medial tibial plateau fracture.
I think two different incisions, you have to go anteriorly, and instead of taking a direct anterior approach, go a little anteromedially, in which you can do fixation of the tibial condyle, medial tibial condyle. You can repair the MCL, and through the same incision by the anteromedial, the orthotomy, medial parapatellar orthotomy, you can fix the ACL, and then you turn around the patient and fix the PCL.
Right.
Thank you so
Ashok,
much.
can I ask one more question? Ashok,
Yes, sir.
Yes, sir.
question to Kakatkar.
Yes, sir.
With a medial collateral injury, with a bony fragment which is comminuted,
Mhm.
in addition to screw, do you ever use anchors?
Yes. For the soft tissue avulsions, there is no alternative but to use anchors. In one of the patients that I have shown, I have used an anchor to reconstruct the MCL fibula, this tibial attachment, soft tissue attachment. and then did ACL fixation with a screw. So if there is a soft tissue component in addition to the bony element, you have to use anchors to reinforce the soft tissue repair.
Okay.
Right.
Thank you very much, sir. That was a wonderful discussion, wonderful display of the technique. Now we invite Dr. Sachin for his lecture on posterior cruciate ligament avulsions.
Okay, thank you very much. I hope my screen is being seen.
Yes.
And I'll be speaking about PCL avulsion injuries. First and foremost, we need to differentiate between PCL avulsion injuries and PCL eminence fractures. So we're going to be discussing avulsion fractures. We're not going to be discussing eminence fractures. Eminence fractures are typically larger pieces, which are the eminence which gets completely involved. And many times you may have a large eminence fracture which involves both the ACL as well as the PCL insertion. So for today's talk, we'll restrict it to PCL avulsion injuries. So essentially, PCL injuries are not uncommon in the Indian scenario, especially with our crazy traffic. Fortunately, for the last week or so, I think all of us have noticed a huge drop in the number of such motor vehicle accidents because of the lockdown. Typically, a dashboard injury which will cause a PCL to avulse from its bony bed in the tibia may also occur with severe hyperextension injuries. The first thing that we need to sort out is the amount of displacement of the fragment, because the displacement of the fragment is going to have bearing on what sort of treatment plan we do. So this is a typical X-ray which one would encounter, and it requires a high degree of suspicion. Whenever you see any form of telltale sign of a dashboard injury, you see this faint linear lucency, which is usually curvilinear, which should draw your attention towards the presence of a PCL avulsion injury. The lateral view may give it away, and many times you may require an X-ray with minimal rotation or with no rotation to help pick up this type of injury. CT scans probably will show in a fracture which is minimally or undisplaced. On the axial sections, you may see an intact hinge of the fracture. And as you go through the various sagittal sections, starting from medial to lateral, you'll be able to approach and see the amount of degree of displacement which is there. And many times it will not be uncommon to see an intact hinge in these situations. The coronal views will also give rise or give indication of the area and the involvement, and also to the degree of comminution as well as the degree of displacement. And as what was shown in the previous talk, whether there is any associated injury to the condyles as well, which may then further lead to compromise of stability and your decision to change your line of treatment. We all love seeing 3D CT scans, and these are extremely crucial and important and give a vast dearth of information. As you see here, these 3D CT scan images of the same patient show the presence of a moderate size fragment which has not been displaced and which is more central in location and which involves the entire footprint of the PCL. Displaced fractures, on the other hand, lend themselves quite easily to early diagnosis on X-rays. As you see here, you have probably a comminuted avulsion fracture, which has risen proximally into the intercondylar notch. And on the lateral view, you can see the presence of a significant lipohemarthrosis as well as the presence of a displaced fragment on the lateral view. CT scans again are crucial because a lot of these displaced PCL avulsion fragments may actually be comminuted, and the degree of comminution definitely has got bearing on the type of surgical approach you choose in these particular individuals. You can appreciate that the degree of comminution may extend within the tibial condyle as well, as is demonstrated here on these sagittal views, and again on the coronal views as well, which show a fair amount of comminution within the crater and which is extending onto the lateral tibial posterior spine as well. The CT scan of the same patient shows the degree of displacement, and as you can observe here, the fragment has ridden up into almost the posterior intercondylar notch area, and this will have bearing on the final surgical treatment that is planned for this particular individual. It is not uncommon that patients come to us with MRI scans, and the critical thing that I would want all of you to observe is how are the PCL fibers oriented. So in this particular example that I've shown up here, this is an example of a minimally displaced or a minimally unstable PCL knee, in which you can observe that the PCL still looks taut, and when you observe various sections, you can observe that the PCL has not lost its normal orientation. It is still looking taut and straight, and probably this will be the first clue that tells you that this patient will not have a grossly unstable knee. And the reason to also observe is that when you see how the PCL fibers insert, they insert on the back of the knee, yes, but the fibers will blend with the periosteum, which underlies, which is anterior to the soleus. And this blending of the fibers is, I think, what is most important to observe. So here's an arthroscopy. You're seeing the back of the knee. That's the intact PCL, which I'm demonstrating with my probe. The red is the soleus, and you can see here that the fibers of the PCL are continuous with that of the periosteum of the tibia. And in contrast, I'm showing here an MRI of the second patient, in whom you can very easily see that now the PCL has lost its normal orientation. It appears to be hooked, or it appears to be wavy. And whenever you see this kind of appearance on an MRI scan, then definitely you will understand and appreciate that this is going to be a grossly unstable knee, and this PCL requires fixation. The other good investigation that one can always do is to do a stress X-ray whenever permitted. So all that you do is to take a true cross-table lateral X-ray with both tibial condyles overlapping with the knee in 90 degrees of knee flexion, and just apply a posterior drawer test or do a posterior drawer stress test. And then when you take an X-ray, you will get a view which looks something like this. What do you need to observe in this? You draw one line along the tibial plateau. You draw a perpendicular to this line, which touches the posterior condyles of the femur. You draw another perpendicular, which touches the posterior-most condyle of the tibia. And this distance, which you observe here, is the amount of distance of the posterior drawer. And if this is more than 4 to 5 millimeters, then this patient requires surgical treatment. So a stress X-ray is probably one of the most important diagnostic tools that we use in our clinical practice, whether it is looking at PCL ligament tears or PCL avulsion injuries. The decision for surgery is based if the knee is unstable or not, and any displacement which is more than 4 to 5 millimeters is considered to be an indication for surgery. So let's consider two examples, one in whom there is a grade 1 or maybe a grade 2 posterior drawer glide, and the displacement is less than 5 millimeters. In these type of patients, you would consider non-surgical treatment, and these patients are best treated with the use of a brace. So a long knee brace is a definite no, because a long knee brace cannot control at all the amount of posterior translation in the joint. What you require is what is called as a PTS, or a posterior tibial support type of brace, which is an extra pad at the area of the calf, which pushes the tibia anteriorly, which is what one must use for doing non-surgical treatment for about 2 to 3 weeks. And the reason why this occurs is that I'm showing an example here. Here we have a patient who has got a PCL injury, who has been rested in a PTS brace. What you can observe is that without a PTS brace, the tibia sags. The moment you put a PTS brace, the tibia is reduced. So using a simple long knee brace is not a good idea. The PCL will not be well reduced. The tibia will sag posteriorly, and your patients will heal with laxity and thereby will be unhappy as the time passes by. After about 2 to 3 weeks, you should get them into a PCL dynamic brace, and on all these braces, you will see one important part. They have a posterior pad on the calf. So this posterior pad on the calf actually will help push or translate the tibia anteriorly, and hence it becomes very important to use a PCL brace and not just a simple hinge knee brace. A straight hinge knee brace or a long knee brace are of no use when you're treating PCL injuries, because they will not allow the tibia to be reduced underneath the femur. The tibia will stay in a posterior subluxed position. Operative treatment is of two types. You can either do it open or arthroscopic. So whenever you have a displaced TCL avulsion with a posterior draw more than 5 millimeters, it can be a comminuted or a non-comminuted fragment. If you have a multi-ligament injured knee, we had a couple of questions saying what shall we do when there is an ACL, PCL avulsion along with an MCL injury. I think that is an indication for surgical treatment. And of course, when you have a patient who has got multiple injuries, say for example, a femoral shaft fracture along with a PCL avulsion or a tibial shaft fractures, I think it's important that we subject these patients for surgical treatment. The ideal time to fix it is, if you're doing an open approach, then anywhere between 1 day to 2 weeks is a good time to fix. If you're doing an arthroscopy, then definitely do not try and do an arthroscopic fixation before 1 week, because you'll have a capsular tear and you'll end up with a messy field, and you will not be able to see anything properly, and you'll get a lot of fluid extravasation, which may then lead to problems. So make sure that the acute inflammatory response is settled if you're planning on doing any form of arthroscopic treatment. The open approach is used when you have a large single fragment which has at least 4 to 5 millimeters of subchondral bone on the same. And of course, I think if you have a comminuted fragment, it is all the more indication to do an arthroscopic, to do an open approach in my hand. The various methods of doing an open surgery are to do the extended posterior approach or the lazy S incision, which is really not required. The Berkshire approach, which was described in almost about 30 years ago, is still probably the gold standard, so as to say. You have two more other approaches that have been described. One is a medial gastroc splitting approach, much similar to the modified Frosch approach, which Dr. Kakatkar discussed in his talk for the lateral side. And you have another approach which has been popularized by Ashok Gavaskar and Bhupesh Karthik, in which they actually mark out the exact location under image intensifier, and then take a small transverse incision and fix it and go exactly in between both the gastrocnemius heads and go straight down, retracting the vessels, which I feel is probably may not be everybody's cup of tea. So here we have a patient who has a dashboard injury. He has a posterolateral corner injury along with a grade 3 PCL. Here we are demonstrating that he has increased external rotation on the affected side. And you can see, compared to the opposite side, that this is a significant posterolateral corner injury as well. The plan for this particular patient was to do an open fixation of the PCL using a Berkshire approach. So here we are marking out the posterior crease of the knee, and of course taking a vertical skin incision that is somewhere in between that of the insertion of the semimembranosus on the tibia and of course the medial head of the gastrocnemius. You would then go ahead and develop a thick skin flap. You retract the retract the superficial and the deep veins, and then you go ahead and open up the fascia which overlies the medial head of the gastroc, as well as that which is in continuation of the semimembranosus. You then retract the gastrocnemius medially, and then you come straight down on the area where you see the rent in the capsule. Once you observe the rent in the capsule, I am taking a couple of stay sutures in the meat of the PCL ligament here, because this was a comminuted fracture. And for the same, the use of strong number 2 high polyester strength suture is pretty much important. A couple of cinch knots are taken so that you get good control on the same. And now here we are observing the other fragment, because since this was a comminuted fragment, we have looked at the other fragment, which is now being fixed with a cannulated cancellous screw. The important tip here is to use a good cannulated system. Ensure that your guide wire is threaded. your screw should have purchase on the opposite cortex. If it is floating free inside the bone, inside just the subchondral cancellous bone, then many times you may not be able to get and achieve good compression. So ensure that you have a good purchase on both the cortices. Then, depending upon the length of the screw, you would then go ahead, drill it with your appropriate drill bit, leave it in place, and then use a screw. This is a 4 mm cannulated cancellous screw with the help of a washer that has been used to fix the one large chunk which we have. You can still observe here that my other comminuted piece has been fixed with or has been held with the help of a high strength suture, and then this will be then utilized to fix the other comminuted piece of the PCL. So after fixing the first piece, you want to go ahead, remove this threaded guide wire and ensure that you have achieved good stable fixation. Then to fix the comminuted piece, we are using a fixation post in the back of the knee again with the help of a simple screw that we use like a fixation post, and that helps sort of put back all the comminuted fragments which are there. Here you can use a short screw, need not be going to the opposite cortex, because this is serving as a simple fixation post. And here we have tied off this comminuted fragment by just using a fixation post kind of repair. So if you have a comminuted piece, the tip here is to take a couple of stitches through the meat of the PCL and then tie it down to a fixation post. And for the large single fragment, you can go ahead very easily and fix it with one simple straight screw ahead. So this is in short how you would go ahead and fix the PCL avulsion fracture by using an open posterior Berkshaffer approach. And this is what the patient's x-rays look like at the end of the procedure. We have done a primary posterolateral corner repair along with a posterolateral corner reconstruction in the same sitting as well. And those two screws demonstrate the presence of the PCL avulsion fixation as well as the small other fragment which is there. Arthroscopic fixation is used if you have a single small fragment. It should be usually what is called as a flake type of an injury, and preferably should be non-comminuted. How should you do it? You need to have good equipment. You need to have a good radiofrequency device. You need to use good instruments. You need a PCL aimer, and you need to use shoulder instruments with some strong tape. And of course, you need a lot of patience if you're doing this arthroscopically. So this is how you will position the patient with the leg hanging down. The other leg is in a stirrup and is out of the way. And you require usually 4 portals, 2 in the front, anteromedial and anterolateral, and 2 at the back, that is posteromedial and posterolateral portals. So this is starting off with the front of the knee. You can see that the ACL appears floppy. The PCL is appearing intact, but here in a sense is torn. Then you create the interval between the ACL and the PCL by removing the posterior septum. And once you've done that, your scope can gain access to the back of the knee. So you start off by working first in the front. You clear the interval between the ACL and the PCL, and then you remove all the soft tissue septum and then enter the back of the knee. Once you've entered the back of the knee, the first thing that you do is to make a posterior-medial portal. So this is the gastrocnemius, and my spinal needle is coming just below the insertion of the gastrocnemius. You make an incision and again carefully remove all the soft tissue from behind the knee, taking care that the shaver blade is looking towards you, because just behind all this fat there are going to be the vessels. And then you break open the septum completely so that you can see from medial to the lateral side. So now we've gone and created a window from the medial to the lateral side, and we've created a posterolateral portal. So the red stuff that you see below is going to be the PCL avulsion fracture. This radiofrequency wand is coming from the posterior medial portal, and that is the medial condyle. We start off by drilling 2 guide wires from front to back by using a PCL guide. these guide wires are drilled from medial and lateral to the fragment. So what you're essentially trying to do is to do something like a double fixation here. So you're trying to use a crisscross pattern, and you're going to press the entire PCL footprint down, which is called as a suture bridge technique. So you create a bridge of suture which is pressing down on the fragment. So the first tunnel that you drilled was posterior-medial. The second tunnel that you're drilling is posterior-lateral, which is coming out here. And you have two cannulated drill bits, posterior-medial and posterior-lateral, and the fragment is bang in the center. Once you've done that, you need to pass a strong tape around the PCL. And so you come back to the front of the knee now. You pass one loop of thread from front to back from the medial side, and then you pass the second thread from the lateral side. And all that you need to do now is to retrieve these threads from front to back outside the tunnel in a crisscross fashion, as what we'll demonstrate now. So that's the first suture that has come from back to front. And now you have the final repair, in which you can see that you've passed a limb of suture around the PCL, you've pulled it down, and now it has been brought out of these two tunnels right here with the presence of a knot, and the whole thing has been pulled down, something like how you would repair a rotator cuff. And this is what is called as a suture bridge technique. And at the end of the procedure, once you restore the tension in the PCL, your ACL will become taut again. So this looks pretty simple and edited in about 3 minutes, but this usually will take about half an hour. So post-operatively, again, you want to immobilize them in a PTS brace for about 3 to 4 weeks, followed by PCL brace for another 3 to 4 weeks, or maybe 2 months at times. I would want them to be non-weight bearing for 3 to 4 weeks, followed by gradual weight bearing afterwards. No range of motion for about 3 weeks till the fragment heals, followed by progressive range of motion. So to conclude, I think it's important to understand which fractures of the PCL require surgical treatment. A lot of them can be treated non-surgically. All the fractures which do not have more than 5 millimeter displacement should be treated non-surgically. Surgery should be reserved for displaced fractures, for multi-ligament injured knees, as well as for the multiple injured patient. My preference is that if you have a single large fragment or comminuted, I prefer an open surgical technique. If there is a single flake-like fragment, arthroscopy is a useful technique. Post-operatively, both are treated in the same manner, and clinically outcomes are the same. Thank you very much for inviting me to this particular webinar, and I thoroughly enjoyed the same. So if there are any questions, I'll be happy to take any for now.
Thank you, Dr. Sachin. That was a fantastic lecture. Most of the doubts to most of the delegates will be cleared. We'll be definitely having question answer. Any comments from the faculty, if you want to comment on this?
Raju.
Yes, sir.
To Sachin. Initially, when the patient is seen, the displacement is only around 4 millimeter. And you have started treating conservatively and realize that within about 5 to 6 weeks, the displacement is increasing. What is your take on this, Sachin?
So you can fix bony avulsions up to 2 to 3 months without any problem. So here, if there is a single large fragment with at least 4 to 5 millimeters of subchondral bone on it, you can go in as late as 2 months or even 3 months and fix it through a solid open approach. So go ahead, open it up posteriorly, curate out all the fibrous tissue as what you would do in fixation of any fracture which is about 2 months old, and then fix it with a compression screw and they will heal. If you have a very thin flake of bone, then that may pose a challenge, and probably based on the arthroscopic view, I would then decide whether fixation at the end of 6 weeks, yes, I will attempt, but anything beyond 2 months, if there is a thin flake, I would not do the fixation and do straight away a PCL reconstruction in those particular patients.
You mean at the end of 2 months, he has lost the chance of arthroscopic repair?
At the end of 6 to 8 weeks, if there is a thin flake then I think he has lost the chance of an arthroscopic repair, because it is going to be very difficult for you to bring that flake down. The reason being is that around 6 weeks, the ligamentization process will makes the ligament contract. So it becomes very difficult from arthroscopically to pull that piece down and try and get it to sit in its proper bed again.
Okay, thank you.
Thank you, sir.
Ashok, do
Sachin,
you
can I ask you? Sachin?
Yes, sir. Yes, sir.
Yes.
Before the advent of arthroscopists like you, this fracture was never treated surgically. It was always left alone. And then I want to know whether there are any reports that those which probably by your criteria today, it requires surgery, if not operated upon, where do they end up into at 10 years' time?
So the most important thing is that if you have displacement which is more than 6 millimeters, then you have very high risk of having a persistent posterior subluxation. And this posterior subluxation, because of lack of the PCL support, the tibia stays subluxed posteriorly. As long as it is a reducible subluxation, these patients will do well. But over a period of time, 5 years, 6 years, 7 years, this leads to a posterior capsular contracture, and then you get a fixed posterior subluxation which cannot reduce back very easily. And once you have a fixed posterior subluxation, these knees will start becoming stiff, they will start becoming painful. And that is why probably the most important thing is that if you see in these patients who do have such injuries, then I think it is always better to go ahead and repair them well ahead of time.
Sachin,
Yes, sir.
I have burnt my fingers when I tried to fix one bony piece which was 6 months old PCL avulsion. So in this kind of a situation, I thought because the piece looked big, I thought I'll be able to mobilize and fix it. But then when I went in, I realized that there was so much of contracture that it was impossible to bring it back to the original position, the original bed of that particular fragment. And then it was a very frustrating experience that we tried to pull it and put a screw, and then it started getting further shattered. So in this kind of a situation, what is the ideal solution? Is it a reconstruction that should be done? And then in that situation, these bony fragments, do they come in your way if you do an arthroscopic reconstruction?
Yeah. Thank you, sir, for your question. So I think in any PCL avulsion which has been neglected or which has gone missed for more than 2 to 3 months, I would straight away do a PCL reconstruction. In this type of situation, I will just leave the fragment as it is. I will not even bother to do anything, and I will reconstruct, leaving the whole native PCL in its natural place as it is, unless there is a fixed posterior subluxation. So if the patient has got a fixed posterior subluxation, which means that fluoroscopically under anesthesia, I cannot reduce it back. Correct? If it is a fixed posterior subluxation, then I will do a two-stage procedure in which I will excise that fragment, remove that bone, and also release the posterior capsule, bring the tibia underneath the femur, and do a PCL reconstruction. But if it is a reducible posterior subluxation, then you can just very well ignore that fragment and do a standard PCL reconstruction and forget about it.
Well, you said that you won't do anything to the original PCL. Then will it not create problem for putting a new PCL when you are doing a reconstruction?
So when you are doing a PCL reconstruction, the whole PCL is intact on the femur. So you're preserving all that collagen. You're drilling a tunnel in the femur, which will be roughly around 8 to 9 millimeters. Your graft will be around 9 millimeters. It will come through that space which is there between the ACL and the PCL. And on the back of the tibia, if this is the back of the tibia and this is the fragment, you bring your graft in between the piece and the tibia and you take it in the front. So you have the tibia, you have your graft, you have the piece. The piece is extreme posterior then.
Okay.
Yeah.
Ashok, I presume there must be a lot of questions. Do we take them one by one?
Yeah, we can take them.
Yeah.
One question by Dr. Swapnil Kutaria. Do we get the same confident feel after fixing PCL avulsion arthroscopically as we get after open screw fixation?
So good question. So the answer to that is that if you choose your indication properly, then definitely you will have the same security of fixation. The important thing is to select your patient for a arthroscopic PCL fixation properly. If you have a comminuted fragment, you will not get that same kind of feel. You need to have a single fragment, which should be sort of like a flake. So essentially, you're sort of reattaching back that flake to the bone. And if you do that, you will get back the same security of fixation as you would normally do if you've done a PCL fixation by doing an open posterior approach.
Right. Another question is, if RM PCL brace is not available, what options do we have after 3 weeks if the brace is not
So,
there?
so you can prefabricate a long knee brace to look like a PTS brace by using a thick, high density foam. So this is what I would do before these PTS braces became commercially available. Just have a good contact in all those people who make pillows and beds, and take high density foam, cut it out to the shape of the calf, and just stick it there with araldite and use it. That does a hell of a lot of good. For the range of motion, then what you need to do is that you get Indian braces, which are dial ROM braces, and in them you stick a similar pad of polyurethane on the back of where the calf is going to be, and again do some jugaad and get your way out of it. It is less than ideal, but if it is definitely not just a simple hinge knee brace or a long knee brace.
Okay. We have more
Right.
questions.
Yeah, another question is from Dr. Taneja. He asked whether we use SS screws or we use titanium ones in this situation.
So I think that's a matter of personal preference. Depending upon patient profile, you can choose a titanium or an SS screw. I don't think that is of much relevance unless and until you're contemplating MRI scans later for any associated injuries that you may be concerned about on day one.
Right. Another question is from Dr. Alok Umre. He asked about post-op protocol and weight-bearing guidelines in these cases.
So if we look at post-op protocol, range of motion, no range of motion for 3 weeks. Then after 3 weeks, start with range of motion in prone position, and then progress to range of motion in supine. About weight bearing, non-weight bearing for 3 weeks, followed by graduated weight bearing. And yeah, that's it. Straight brace for about 3 weeks, followed by mobile brace or a hinge brace.
Okay.
We have more.
Yeah, we have another question by Dr. Tejas. What is the position while tightening the screw and pull through technique? Position of the knee while tightening the screw.
Okay, so if you're doing it arthroscopically, the position of the knee is between 70 to 90 degrees, because that is when you want to ensure that the PCL is tight. And when you're doing that, you give an anterior drawer to the tibia, and then you pull on the threads and you tighten them anteriorly, either on a fixation post or over a bone bridge.
Right. Any other questions from the panel?
Yeah. Sachin, most of these patients have a tendency to go for a deep venous thrombosis, some of them. So is there increased incidence of DVT? And how do you do a thromboprophylaxis?
So to be very honest, I have not used thromboprophylaxis in any of my patients till date, especially with isolated PCL fractures, avulsion injuries. Arthroscopic fixation, if you go in early before 7 days, then you have a slightly higher risk of getting extravasation and a compartment-like syndrome. DVT, personally, if you are good in your soft tissue handling, if you're doing an open approach, then I probably have not seen any patients come back with DVT as such. So I'm afraid I don't have any data on that really.
Well, Sachin, if the patients have comorbidities like obesity, diabetes, or anything, then do you think the chances of developing DVT are more, and you should think of thromboprophylaxis?
So if you are at any of those high risk groups for DVT, which means you have abnormality of the vessel wall, or if you have abnormality of the coagulation, not coagulation profile, if a coagulation mechanism, or if you have, if you're going to have a prolonged surgery with the patient being in the prone position with a lot of soft tissue handling, then definitely it would not hurt to give these patients DVT prophylaxis at all.
Nowadays, we see a lot of young people having hypertension, diabetes, and in these patients, 3 weeks of no
Aspirin.
range of movement.
Yeah.
I think in these patients, it will be a little more.
I think so.
safe
So
to-
all of my patients don't get chemo prophylaxis, but they will be using DVT stockings for sure. One, and you should encourage them to do a lot of active ankle movements and calf pumps. So you are doing sort of mechanical DVT prophylaxis. It would not really hurt to add aspirin for these patients post-op. Absolutely no problem.
Okay.
Sachin, there is a question for you. How
Yeah.
to treat a ACL avulsion and a grade 3 MCL?
ACL avulsion with grade 3 MCL.
MCL.
Acute injury? I
Acute
presume it is
injury. Yeah.
So I
acute injury.
think, so I think if it is a grade 3 MCL, then it requires open MCL repair with augmentation. So my preferred approach would be to do a medial approach, go and do dissection layer by layer, observe the injury pattern on the MCL. So first I would start off by repairing layer 3, which is the meniscotibial and the meniscofemoral ligament and the deep MCL. Following that, I would go ahead and repair the medial retinaculum and the superficial MCL in layer 2. If it is a mid-substance tear, then I would do an augmentation of the MCL at the same instance. So I would use either the semitendinosus, which is left attached to its insertion on the tibia, and we harvest the semity, leave it attached onto the tibia, put a suture anchor there and do a tenodesis, and then take that semity proximally to the femoral insertion and fix it there, so that you have got something like biological augmentation as well. So that will finish off the MCL part. For the ACL, depending upon your skill set and the personality of the ACL avulsion, you can either choose to fix it with a single screw, or you can use the same thing in which you make 2 tunnels and take suture tapes and bring it out. So because it is a grade 3 MCL ACL, the medial capsule has already torn. So nature has already made an arthrotomy for you. So I would just sort of extend that nature's arthrotomy, if I can say, and go ahead and fix the ACL first and then repair the MCL in the same sitting.
Okay.
Any other question?
Yeah, there is a question by Dr. Mukesh. He said he had one case where PCL avulsion was fixed, but after 3 months, patient had a posterior sag grade 3. So is there a way to predict this on MRI, or what has gone wrong with this?
Okay, so this is a quite an unusual situation in which you have a scenario where the PCL avulsion was fixed, but the patient has got a posterior sag. So look out for 2 things. One is that many times, because the exposure or the visualization through a Berkshire approach is limited, it may so happen that we fix it, but it is not fixed to its original bed. We end up fixing it in a less ideal position. So it is not fixed low down, but it is fixed more proximally, which can result in a persistent
Laxity.
posterior subluxation. The second is that it may not be uncommon to have a bony avulsion along with disruption or a partial tear of the PCL as well, in which you fix the avulsion to the right position. But because there is loss of continuity in most of the fibers of the PCL, it is the ligamentous part of the PCL that gives way and leads to a subluxation later on. And the way about this is to again see if the subluxation is fixed or reducible. If it is reducible, then I think do a PCL reconstruction and forget about it. If it is a fixed subluxation, then do a stage 1 procedure in which you release the posterior capsule, bring the tibia underneath the femur, and then do a PCL reconstruction at a second stage.
So taking that thing ahead, do we recommend MRI for all these cases where we see avulsions on X-rays to see mid-substance tear?
Okay, so it is extremely unusual to have a mid-substance tear and an avulsion in the same ligamentous
Right.
complex. It will be, I think it will be a case report if you ask me. It is, I have not seen till date any patient who's got, a torn ACL and an ACL avulsion. It has to be extremely
Right.
unusual. So for me, MR is not the standard of care. Most of the patients, when they come to me, they already have an MRI. A lot of them do not have
Ah,
CTs. So the thing that I end up asking them to go and have done is a CT scan, just to see the bony osseous anatomy a lot more better.
Yeah.
right.
So,
There's another question by Dr. Alok who asked,
yeah.
have you encountered any wound complication for open PCL repair? He has seen few cases of delayed healing in his series. So your opinion on that?
Yeah, it is not uncommon to land up with a small portion of the suture line having delayed wound healing, especially if when you're doing the Berkshire approach, if you curve it at right angles, correct, then many times that corner may get necrosed. You have to be gentle with your incisions. Don't try and do it through an MIS approach, because the more pushing and pulling you start doing, the more compromised the blood supply is to the skin flaps. So raise thick skin flaps right down from the deep fascia, and have a generous exposure. There should not be any tension on the wound margins, and thereby you'll be able to decrease or minimize the chances of any sort of wound complications setting in.
I
Right.
think it is the soft tissue handling which makes a lot of difference. I think under the name of minimally invasive, I have seen people really messing up with the soft tissues.
Yeah.
Right.
Sachin, there is a question. If you want to immobilize ACL and PCL, what positions would you prefer?
So PCL will always take preference, and if you have a ACL PCL injury, PCL takes predominance, and all the immobilization has to be done as per the PCL.
Okay. There is just one question from Dr. Tejas from Baroda. Is there a role of aggressive quadriceps strengthening during rehab for PCL avulsion patients?
Not really, because I really didn't I understand that question. So,
Role of aggressive quadriceps strengthening during rehab of PCL avulsion patients
so if you
after
look at the
fixation.
after fixation, the rehab will follow the three phases. First is going to be the phase of immobilization and maintenance of muscle tone. In the second phase, you start knee flexion and get movement first. And for that, you will encourage knee flexion in the prone position. And in the third phase only, you will go to muscle strengthening and rehabilitation. So the rehab will not change much. You will encourage the patient to do closed chain and some open chain exercises, depending upon how the patient is feeling.
Right. I think I have exhausted all the questions that we have.
So,
Sure.
anything Tanna sir wants to comment?
So I think
Can
Tanna
we-
sir has muted himself. You'll have to
Can we
unmute
unmute?
yourself, sir.
Yeah.
Tanna sir, you want to comment on something?
Yeah, I wanted to ask something.
Yeah, sir.
Please, sir.
Sachin, as we talk about in ACL, if it is not operated upon, patient can settle down to a reasonable life with the development of the quadriceps. Is there anything, something like this in the PCL also?
So if you have a PCL, which if it is an isolated PCL injury and up to grade 2 drawer, he will have a reasonable non-sporting life, absolutely without any problems. If it is a grade 3 isolated PCL, and if it is a combination of PCL along with either MCL or the lateral side, then he will not have a good outcome irrespective of asthma, whatever rehab you do.
No, I'm sorry. I'm committing myself.
Yeah.
Only PCL isolated injury.
Yes.
Where there was an instability.
Correct.
And the patient didn't undergo surgery.
Correct.
And with the development of the quadriceps over the time.
Correct.
Probably the peaceful coexistence was achieved. I don't know whether he improved upon or whatever it is.
Correct.
He stopped complaining of anything else at all.
Yes.
Now, is it possible?
Of course, it is possible. So up to grade.
Hey, I'm talking about a grade 3, which otherwise you have advised surgery.
So grade 3, you can achieve good quality of life, which is what shall we say, Tegner scale 5, which means you can do light recreational work. Up to light recreational work, you can achieve good harmony. But anything beyond light recreational work, if you want to do, then you will start getting into problems.
So in a non-sporting people, those
In
who
a-
are comparatively casual exercises who do, for
Yes,
them it is all right, you think?
it is all right, provided the things that you will not be able to do properly or which will land up in problems is going to be any form of moderate exertion, say like walking for more than half an hour, or gradual uphill climbing, and staircases more than 3 per day. If you are able to avoid these three, then a grade 3 PCL, you can have a decent quality of life with good rehab.
Oh, thank you very much. Thank you very much.
Sachin, can I ask, Sachin?
Yes, sir.
A patient with ACL symptomatic becomes asymptomatic only with the quadriceps developing. Is there anything like this in PCL?
So there are two parts to this question. I think the first part is, does a symptomatic ACL become asymptomatic? Well,
Do you agree to that part? Do you agree to
exactly.
that part?
Exactly. So about 40% of all isolated ACL tears without significant meniscal tears will fall into the group of copers. So around 40% of ACL ruptures, isolated or small meniscus tear, are ACL copers. They will cope and they will be in a symbiotic relationship with themselves without surgical intervention. About 60% of them will continue to have instability and symptoms, and they are the people whom, if you don't treat surgically, will land up in further problems. On the PCL side, isolated PCL, almost about 70 to 75% patients of grade 3 PCL tears are going to be copers, provided they follow a relatively light recreational quality of life. Anything beyond light recreational, if they want to do any form of sport, they want to play badminton twice a week, or go up small hills, or climb staircases, 4 to 5 flights of stairs, then they will not cope up with the same. So I think it all has to do with activity level as to what is your sweet spot, which will allow you to determine where you should be going.
Now,
Sachin,
these people whom you advised,
Yeah.
if they wear a splint or a hinge splint or something, could they be improved upon for those activities?
So if you are treating anybody non-surgically, you should be in a dynamic PCL brace for at least 4 months. That grossly reduces and brings down your instability from grade 3 to grade 1. So the use of persistent use of a good dynamic brace is pretty important and pretty critical at this juncture. And it can definitely help you get you into that comfort zone area where you can be happy without surgical treatment.
How long you will advise that?
6 months, 3 to 6 months.
And after
They have to
6 months,
use
he
it.
can. After 6 months, he can do without brace.
So his laxity will come down from grade 3 to about grade 2 or grade 1, and he will definitely improve. Of course, there is going to be a subset of patients within this group who are still not going to settle down, and those are probably the patients whom will come back to for intervention later on.
So
Sachin,
if I can put it down,
Yeah.
that people over 40, 45, if they do not undergo surgery, they will be able to have a reasonable life without surgery, if at all needed, with the splint occasionally. Would it be right, or you think it will not be right?
So I will rephrase your statement.
Yes.
Patients above the age of 45 who do not wish to do anything more than light recreational activities can be treated non-surgically for isolated PCL injuries up to grade 3, and they will be able to enjoy that quality of life, and almost 80% of them will be happy non-surgically.
Thank you for clarification. This was, I think, very important.
Thank you.
Sachin,
Thank you.
Thank you.
Sachin,
Yeah, go ahead, sir. Kakatkar, sir.
one small question. Right now, we were discussing that whether developing quadriceps for an ACL deficient knee is going to solve the problem. So, is it the quadriceps strength which is important, or the hamstring strength which is important for the ACL deficient knee?
So what was possibly what we always thought was that if you develop good hamstrings, then the hamstrings contract and it does not allow the tibia to sublux anteriorly in an ACL deficient knee. But if you look at the reaction force time, so if this is an ACL unstable knee, force is applied and the knee has to buckle. The knee will buckle in about, I don't remember the exact numbers, but I think 0.14 milliseconds or something like that is the time taken for the knee to sublux or buckle. And the fastest contraction of a hamstring in a person who has the best hamstrings developed in the whole world is roughly around 0.36 milliseconds. So even before the hamstrings can contract, the knee has already subluxed. So a very strong hamstring cannot compensate for a uncompromised or a non-copper ACL deficient knee.
Okay.
Perfect.
Yeah. So if you are a non-copper, you will remain non-copper irrespective whether you do 10 hours of gym every day or whether you don't do anything every day.
Okay. And
Sachin,
this
Overall,
is
if I ask
what-
you, we observe that when we ask the patients to develop the quadriceps or overdevelop it, almost it is impossible for those people above 40, 45. They try whatever they want to sincerely also try, but they can never get the quadriceps exactly like even the opposite side.
Correct. So one good trick for that and one good treatment modality which we have now is what is called as BFR or blood flow restriction therapy, which a lot of our therapists do use nowadays. So in this, essentially you tie a tourniquet just above the venous occlusion pressure on your thigh, send the patient to a gym and get them to do 3 reps. There is a specific step down of those reps. So essentially you're making the patient do active open chain exercises and strengthening in an anaerobic environment. And because of creation of that anaerobic environment, you will see actual hyperplasia of the muscle cells and hypertrophy of the individual muscle fibers as well. So in case you are left in a situation where you have a patient who requires that bulk to come on, please ask your therapist to put him on BFR therapy or blood flow restriction therapy. And a lot of these patients will get back at least 80% of their muscle bulk.
Thank you for that piece of information. That was very informative.
Yeah.
Yeah, I think
Thank you, sir.
हमारे जैसे लोग को ये बहुत इम्पोर्टेंट है यार.
Alright, sir.
Sachin, there is a comment for you that you
Yes, sir.
wonderfully demonstrated a comminuted PCL fixation. The
Thank you,
suture
sir.
you use, what is
Yes.
that suture you use to drag it down? Is it a small needle or is it a large needle?
It is a number 2 commercially available high strength suture, ultra high molecular weight.
The name of the suture person is asked.
Ultra braid it was. Number 2 ultra braid. Yeah.
Okay. Fine. Perfect.
There is just one more question. In case of untreated PCL avulsion fracture, does it predispose to any other knee injury? Like ACL untreated predisposes to meniscal.
So ACL will lead to instability, PCL will lead to disability. So the only thing that the PCL that an untreated, neglected PCL will predispose to will be osteoarthritis in that knee. That is the only thing it will lead to.
Okay.
Yeah.
Okay.
But the evidence which is there that ACL, whether treated or not treated, osteoarthritis is not related to. Is it also true for the PCL or no?
So the data that we have on ACL, whether reconstructed or non-reconstructed, will lead to osteoarthritis. There is fine print which one needs to read in that. It is not a prospective randomized double-blind trial that all isolated ACLs are either receiving non-surgical or surgical treatment. So if you look at the subset of ACL tears which have had surgery, they have all had meniscal tears. They were all patients who were non-copers, which is why they had surgery. So the presence of the meniscal tear is the confounding factor which has led to the development of osteoarthritis. On the other hand, the non-surgically treated patients did not have meniscus tears. So probably it is not a very good comparison to see, that you're comparing non-surgically treated isolated ACL tears without meniscus tears, and you're comparing them to operated ACL tears with
With
meniscal tears. So that is probably the biggest confounding factor in sort of relating both these groups. For the PCL, we definitely have data for sure. And if I remember my Campbell, when I was studying orthopedics about 1993, 94, the only thing that was written in Campbell then was that these patients required a high tibial osteotomy, and the other procedure that was described was remove the medial head of the gastroc and reattach it on the medial side or something like that. So that was probably the only two surgical treatment plans that were written, I think, in that old Campbell. I don't remember which edition it was.
अभी तो नहीं करता है ना ऐसा कुछ.
अभी है तो मैं तो कभी देखा ही नहीं आज तक. तभी भी नहीं देखा, अभी भी नहीं देखा.
वही बोलता है. Lovely, Sachin. It was
Thank you,
superb.
sir. Thank you, sir. Thank you very much.
That's superb. Yeah.
Thank you, sir.
Thank you.
As
Thank
usual.
you. Thank you to both the faculties and both the experts. We had a wonderful discussion and we have a lot of carry home points from Dr. Kakatkar sir's presentation of doing a compression drilling by K-wire to avoid entanglement of the fibers of the ACL, to Dr. Sachin, who gave wonderful insight into not only operative procedures, even into bracing and position of immobilization. I hope that would be very useful to all of us. And we are really thrilled to enjoy this feed from webinar from Dr. Ashok. Dr. Ashok Sham, I must thank you for providing this platform. This platform is really making us utilize the time in so beautiful way. Thank you so much for giving this platform. Thank you.
Thank you.
Thank you, Panna sir and Babulkar
Thank you
sir
all.
for giving.
I think I accuse Ashok. He is making our ignorance so much obvious by attending these seminars. That now we have started feeling what the hell bloody we know about them.
And the best part of the seminar is that we have time and there is no restriction for time.
Absolutely
Really
true.
5 minutes,
Absolutely
8
true.
minutes. So person and speaker can pour their heart out in their topics. So thank you very much for that.
Probably with this month, we will stop really doing the real meetings, and all the meetings should be like this only. Slow moving, easily, everything being talked, and not time you ask the questions in the tea break and ding, 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 dings and all. So this is, I think, a wonderful meeting. Thank you very much.
Thank you,
Thank you.
Ashok. Thank you, sir. Thank you
Yeah,
very
I
much.
think
And
we also
Dr.
thoroughly enjoyed this.
Raju, thank you very much for a beautiful seminar.
Thank you so much. Thank you so much. Sir. With all your wisdom, we will be imbibing all the wisdom from all the speakers. And let us continue this series till the lockdown period is there. And Ashok has given a consent. Yes, we can go ahead.
Kitna
Yes,
हैरान
sir.
करेगा sir.
Yeah, he's so busy. There are four seminars lined up today. And I think we'll be listening to Dr. Sachin in the evening also.
Yes.
Yeah.
Thank you.
Okay.
Thank you, sir.
I think
Thank you.
all